You're live.
Good morning. This is Senate Health and Welfare, and it is March 26th. This morning, we're looking at some of the bills that have come to us from the House, and look forward to hearing about two bills in particular, the CON bill and the 340B bill. We'll just identify them as that. And so first we have H96. Mari Ford is here, your reporter and sponsor. If you want to come and check, take a seat. And then we'll go through the bill briefly with Jen. This is our first look, so we won't be spending a lot of time. We'll just try to get clarity on what's in the bill.
So you don't want me to do a line by line?
Huh?
You don't want me to do a
No.
line by?
I don't think you want to.
I don't know. Good morning, everyone. I'm Representative Mari Fortis from Bristol, here to introduce you to the this bill about the certificate of need process. And I know many of you are familiar with the certificate of need process, but it might be good to give you a little background.
That's helpful.
Okay.
Please, yeah.
So certificate of need process was originally required of states by the federal government in 1974 and eventually repealed in 1986. And it's a process by which states like Vermont, currently through the Green Mountain Care Board, but it used to be through VSCA, the previous sort of iteration of the Green Mountain Care Board, that evaluates the impact of how we spend money on healthcare in Vermont. And the intent is to protect the public good and be able to oversee the financial implications. When we're spending lots of money on healthcare, we want to know, are they wise expenditures, and are they good? Is it a good use of our precious taxpayer dollars and our precious healthcare dollars? So certificate of need laws are another intent of the process was to prevent duplicative spending in healthcare. And as I'm also a registered nurse and have been for 37 years, so I've seen a lot of the evolution of our healthcare system. And used to be, just for an example, I'm not talking about certificate of need process now, but I'm talking about medical spending. In the hospital, for example, each surgeon might have a favorite tool that they like to use. And so the purchasing department would order that surgeon's favorite tool, but then this surgeon has another favorite tool. And then it would add expense because they were having to like track down multiple different kinds of tools that do the same thing. So in the healthcare system, if multiple facilities and multiple entities are doing the same thing, when there isn't maybe a need for that many of that same thing, the certificate of need process helps reduce that duplicative spending. 35 other states have similar processes, but what we know is that Vermont's certificate of need process is the most extensive. So what H96 seeks to do is to reduce the regulatory burden for healthcare entities wanting to do a number of things, and I'll go into those as I go further down into the bill. So this is a bill to reduce regulatory burden, not only for the healthcare entities, but for the Green Mountain Care Board. We've got as you know, some really big issues facing us in our healthcare system right now. And we want the Green Mountain Care Board to have as much capacity as possible and not to be caught up in having to go through the certificate of need process for healthcare expenditures that maybe aren't as worrisome. The certificate of need process is extensive. It's can be a bit onerous. And it can take a really long time. There's a hospital in southwestern Vermont that has been working through the certificate of need process for a youth mental health addition. And it's taken them a long time. I think just the other day they were finally approved. That program was finally approved, but It took way too long, and then it cost overruns because it took so long. So we want to prevent that from happening. And national data shows that these kinds of burdens have a more significant impact on rural communities by reducing access to healthcare services. And that's another issue with the certificate of need process. It doesn't always lead to improved quality outcomes either, or improved access. We in your committee and in my committee in House Healthcare, we talk about access and equality often. Certificate of need process doesn't necessarily help those, and sometimes it hurts. And I know you have talked about freestanding birth centers. Our certificate of need laws or process are one of the primary reasons that freestanding birth centers have not been able to establish themselves here in Vermont. In addition, freestanding outpatient surgery centers, it took a long time for them to get established in Vermont, and there's still only 2. Vermont currently ranks last in the country in terms of access to freestanding outpatient surgery centers. And these centers also are known to provide quality services at lower cost. So we want to invite that kind of healthcare entity to flourish in Vermont. Just to give you a sense of what is involved in the certificate of need process. The applicant there's lots of paperwork and filing. Interested parties people or stakeholders can ask to be classified as interested parties, which means they're much more involved officially in the process. And a CON is granted if the applicant demonstrates that the project serves the public good, it aligns with statewide healthcare reform goals and principles. The cost of the project is reasonable. The applicant can sustain the financial burden, and that there's no undue increase in cost or undue impact on affordability. It examines what the financial impact on other hospitals and clinical settings would be of this, whatever the healthcare project is. And the list goes on. So I think that the certificate of need process is important. We still need it, again, because we want to protect our precious healthcare dollars. And it is a way of getting everyone at the table and looking at that. We just want it to be less onerous. So the bill itself, I'll just go over an outline of it. The main things that we changed were the financial thresholds that would trigger a requirement that the healthcare entity go through the certificate of need process. So on the first page, section 1 addresses the certificate of need process thresholds for everything but hospitals, a healthcare facility other than a hospital. And the first threshold that we changed was the construction, development, purchase, renovation, or other establishment of a healthcare facility or capital expenditure for which the capital cost exceeds, and the original threshold was $1.5 million. And we bumped that up to 10 million. And I should say here, one of the great things about this bill is that all the stakeholders were involved in helping, including the Green Mountain Care Board, who wants this bill to happen. So there's agreement, there's unanimity, and there's everyone got involved, and we arrived at this point here.
So you don't have to go through all the sections because we'll have Jen do that, but if there are specific areas that are important, like threshold?
Yeah, I'll just do the outline.
Yeah,
Um,
okay,
so that was the first threshold, and again, we're talking about non-hospitals. The next threshold was, had to do with purchase of diagnostic equipment. And that threshold was 1 million and we brought it up to 5 million. And then there's a section in there for, ambulatory surgical centers. And then the next section does address hospitals, and then we go through the same thresholds, but for hospitals, the capital expenditures, construction, development, purchase, renovation, was 3 million, now is 10 million. And then there's the diagnostic and therapeutic equipment, same, it's just echoing what was in the previous for non-hospitals. That was 1.5 million, is now 5 million. And then operating expenses, 3 million, now it was 1 million. And then there's a section that talks about any expenditures in excess of $30 million. That's in current law. We raised that threshold to $50. So that would require a conceptual development phase certificate of need, and Jen can go into more detail about what that means. So it's when it's an additional process that an entity would have to go through if the expenditure was more than $50 million. And again, the previous threshold was $30 million. And the last thing, two things that I want to mention are three things actually. We excluded emergency and non-emergency first response folks from having to go through the certificate of need process. We don't want to encumber them from having to go through any of this. And I mentioned the issue with the Southwestern Hospital having cost overruns because the process was taking so long. We added a section that deals with what to do if there is, while this bill is working through the system, and once it's passed, should it be passed, what to do with certificate of need processes that are already ongoing. And there's some language in there that Jen can explain. And again, Green Mountain Care supports it because it helps them focus on the really big work that they have to do. And it also increases, it removes burdens to access to care for our rural communities and for some really important lower cost, high quality healthcare services that we do want to have succeed in Vermont, especially now when our healthcare system is so uncertain.
so your committee did make some changes to the bill as introduced.
We did.
Yeah.
Yes.
Okay. And Jen will share with us what
Yeah.
that was. Good. Okay.
Yeah. And it voted out of our unanimously out of our healthcare committee
Terrific.
with one person absent.
Great. That's good. Questions from Ari? So, yeah, so the replacement equipment is something I remember when I was teaching histology and showing folks how to do embedding and sectioning, and the UVM was getting rid of their Big Bertha machine that did all the embedding, and I thought, oh, this is because we were doing all my hand teaching.
Oh, goodness.
And they got one for $30,000. I thought, whoa, they had to go through the CON process to get the replacement. Now they all right. Any questions? So we'll ask Jen, but maybe you know when the last time these levels were changed with, because obviously inflation and medical inflation in particular has caused costs to go up. So do you know?
I don't recall that they have been in a long time.
Yeah, but yeah, we can never remember doing. Yeah, I do. I remember doing that. I don't remember whether we actually did it. I don't know how much it was.
Thank you, Madam Chair. I've spoken to Representative Portis about this. Yesterday we passed S18, as you know,
Right.
the birthing center bill. And it's very important that birthing centers don't have the barrier of a certificate of need, which, you know, in our bill, it's carved out, but in this bill, there is one area where it could become a detriment to birth center.
Well, we'll talk about that when we
Jen.
get to Jen and we
Got
start going through the bill. Yeah, the question will be how this sugars off between what your committee does and what our committee does on birthing centers. So we'll have to figure that one out.
Yeah, that's one of the, on page 2, number 3 of the, instances of a non-healthcare facility.
Okay, well, when we talk with Jen, we'll kind of sort it out. Okay, yeah, that's good.
Yeah.
All right, any other questions here?
Feel free to grab me in the hall or send me.
Sure, I actually have email I want to share with you, if you don't mind.
Is it regarding this bill?
Yeah.
Okay, well,
It's regarding Central Vermont Hospital having a walkout on Saturday.
okay, well, this is, hold that thought, and we'll get to that at the end of the committee meeting. We'll talk about that. So, any other questions for Mari on page 96? So you're lucky. This is good. Thank you. Thank you for your work on this. It's really important to go through this, and I know that this partially came out of the Oliver Wyman report for Act 167, and then also a recommendation from the board. So it's nice to hear that there's a lot of agreement. All right, thank you.
Thank
So Jen, why don't you walk us through the bill?
Good morning, Jen Carvey from the Office of Legislative Counsel. I'm put this up. Screen. And Madam Chair, you mentioned some things you would ask me while I'm here. Some of them I may have to get back to you on because I had not looked at particularly at the timing of the
Okay, yeah,
changes to
no
the numbers. Or done a comparison of the bill as introduced. Through a few iterations. of the
Okay.
House committee. I'm happy to get back to the committee with something you're interested in. So we are looking at H96, an act relating to increasing the monetary thresholds for certificates of need. This committee may remember that we had looked at a couple of different bills on this topic back at the beginning of the session. There were a couple of bills in this committee, S10 and as something else, as 20.
As something else.
S10 and S20. And so this is, I believe this one is similar to S20, but with some modifications, some combinations between the two,
Okay.
because those were looked at in the House. So this amends first in section 1, 18 VSA section 9434, which is the general rules on certificates of need and where it sets out the monetary and other threshold triggers for requiring a certificate of need. The first change you'll see here, I think maybe what Senator Gulick was getting at with the lead-in language that a healthcare facility other than a hospital shall not develop or have developed on its behalf a new healthcare project without issuance of a certificate of need. And for purposes of this section, a new healthcare project does not, this would change it from includes the following, which is an inexhaustive list that I know was of concern to some advocates of the birth centers, to say means all of the following. So it is now an exhaustive or exclusive list. It is specifically these items, and there is not room for additional assertion of certificate of need jurisdiction. So a new healthcare project means any of the following. And then the first is the construction, development, purchase, renovation, or other establishment of a healthcare facility or any capital expenditure by or half of the healthcare facility for which the capital cost exceeds, and this would increase that threshold from $1.5 million to $10 million, One thing to note here that I think we talked about back in January, is that while the 1.5 million is the statutory number, there is existing language in the statute that authorizes the Green Mountain Care Board to index those numbers and increase them over time to keep pace with inflation, and they have done so. So some of these numbers are in actuality a bit increased already from what is in the statute. So I think the 1.5 million is slightly higher than 1.5 million, for example. And this bill does keep that, actually is now a mandatory index, not a discretionary index. Although it's my understanding that the board has in practice applied that index. So no change in subdivision 2, which is a change from one licensing period to the next in the number of licensed beds. No change to number 3, the offering of a home health service or transfer or conveyance of the ownership of more than a 50% ownership in a facility other than hospital or nursing home.
So that's where my issue lies.
Oh, interesting. Okay. Yes, as I was just saying, and it made me wonder.
So I
We will
could be a
have to
barrier.
look at that. Well, there is no requirement that it receive a certificate of need, but it may make sense to make a conforming reference in 3 to say other than a hospital, nursing home, or birth center, if that is the intent.
That might be something we want to look at.
Yeah, I want to look at the phrasing of the exclusion for the birth centers, but that is a good question that I don't think came up, so let me just look at. Yeah.
So when we'll take testimony, and when we come back, maybe we can look at that as we're taking testimony.
Yes, yes, and
Yeah.
S18 is getting taken up this
Yeah.
week upstairs as well, so it'll just make sense to
It'll be a
keep-
balance.
Right, it may make more sense to keep the birth center language with the birth center bill,
Yeah.
otherwise you have for some reason, that one didn't make it across the finish line, you'd have a sort of random reference here. Otherwise, if we put it in that bill, it go along, when we're putting these into statute books over the summer, all of the changes will appear in statute. All right, number 4 is the next place we have a change. This is the purchase, lease, or other comparable arrangement of a single piece of diagnostic and therapeutic equipment for which the cost is in excess of, and this increases from $1 million to $5 million for that threshold. And then it keeps some existing language about basically you can't sort of break up what would normally go together and are necessarily interdependent into separate purchases in order to try to skirt the requirement, the calculation requirement. Number 5 is the offering of a healthcare service or technology having an annual operating expense that exceeds, and this would increase from $500,000 to $3 million for either of the next 2 budgeted fiscal years, if it was not offered or employed within the previous 3 fiscal years. Number 6 is the construction, development, purchase, lease, or other establishment, and this would add or expansion of an ambulatory surgical center, and now this would put a dollar amount in for the trigger for an ambulatory surgical center, which would be a cost that exceeds $10 million. Right now, there is no monetary threshold for ambulatory surgical.
And it might be helpful here just to acknowledge that there are slightly different processes at the board for ambulatory surgical centers or ophthalmological centers. And we went through some differences in the CON process for those as compared to hospitals.
Well, the hospitals have their own,
Yeah.
their own section here. And I would defer to the board on whether their processes are similar or different for.
Well, I was thinking of the statutory changes that we made a few years ago relative to some of these. Okay, we don't need to talk about that now.
We did create a process in statute a few years ago to license ambulatory surgical centers and to specifically subject them to the certificate of need statute. And at that time, there was not a monetary threshold for certificate of need. Now, in this bill, there would be. All right, and then similar changes made in subsection B, hospital. So the last one is healthcare facility that's not a hospital. Now we're in hospital. Shall not develop or have developed on its behalf a new healthcare project without issuance of a CON by the board. And here again, keeping that new healthcare project means any of the following, not includes any of the following. And we have what I'm just going to refer to in shorthand as the construction or capital expenditures in excess of $10 million instead of the current $3 million. The purchase, lease, or comparable arrangement of a single piece of diagnostic and therapeutic equipment. That threshold increases from 1.5 million to 5 million. The offering of a healthcare service or technology with an annual operating expense that exceeds $3 million for either of the next 2 budgeted fiscal years, if the service or technology is not offered within the previous 3 fiscal years. Change from one licensing period to the next. So no changes here. Change from one licensing period to the next in the number of licensed beds, and the offering. No changes to the offering of any home health service. It is possible if this committee decides to make changes to this, I may look at whether it makes sense to just combine all of these into a single section that doesn't break them out. Because now that the monetary thresholds, I believe, are aligned, it may not make sense to keep them separate, but we can look at that. Cool. Subsection C, this is the conceptual development phase certificate of need that Representative Cordes was mentioning. So if it's a project that requires a CON and the expenditures are anticipated to be in excess of, and this would raise that threshold from $30 million to $50 million, the applicant first has to get a conceptual development phase certificate of need, and that way they can make expenditures for architectural services, engineering, design services, and other planning services as necessary. And then just a informing reference to that same increased number on lines 19 and 20, 30 million to 50 million. And then it would increase the amount of expenditures that may be made in preparation for getting the conceptual development phase certificate of need from the current $1.5 million for non-hospitals and $3 million for hospitals to $10 million for any healthcare facility. And then this is the language that is in existing law. I guess it's still discretionary, but the board in practice does periodically adjust the monetary jurisdictional thresholds contained in this section. And as the current law says, any adjustment shall not exceed an amount calculated using the cumulative consumer price index rate of inflation. So that is what the board is currently doing, is indexing, and that could continue. Section 2 adds to the list of exclusions. So this is where we put the birth center in the birth center bill. We put the birth center exclusion in here. So these would be combined if both bills pass. But a new exclusion for routine replacement of fully depreciated medical equipment. And then it makes some kind of clarifying changes to the existing exclusion for non-medical equipment and fixtures, regardless of their remaining useful life. So in A, it's just medical equipment that is fully depreciated, and B, it's non-medical equipment and fixtures. It doesn't have to be fully depreciated. It can have remaining useful life if appropriate to replace. And then a new exclusion from the CON subchapter. Excluded from the subchapter are emergency and non-emergency ground ambulance services, affiliated agencies, and equipment and supplies used by emergency personnel. And it piggybacks on the definitions of those terms from the municipal law statutes that have pretty extensive definitions. Finally, we have section 3, the effective date. The act would take effect on July 1st. And this is what Representative Cordes was referring to, a little bit of additional information here. So it would apply to all new healthcare projects initiated on or after July 1st, 2025. But when we're addressing applications for a certificate of need that are already in process on that date. And if one or more persons have been granted interested party status, which is an official status within the CON process, the board has granted interested party status to one or more persons, then the jurisdictional thresholds and exclusions in place at the time the application was filed will continue to apply until a final decision is made on the application. So keep going as you're going. For applications for a certificate of need that are already in process on July 1st, 2025, for which no person has been granted interested party status, the applicant may withdraw the application in accordance with board rules, and then they would not need to pursue the, finish the certificate of need process. So if it's significant enough that that somebody's been granted interested party status, they would keep going with the CON that's already in process. If nobody has requested and been granted interested party status, then the applicant could withdraw the application and just proceed with their purchase of a project.
Good, thank you.
So that is it.
So clarification, questions of clarification committee, oh, good. Here.
The one, just that
Then-
one
Yep,
section.
the
I
one
think it's a great
concern
idea.
that Senator
Yeah, I think
Brewer,
it's
and it's a
Great
legitimate
question. Yeah. And I think, I'd like to, particularly think about it in the context of SAT.
Okay, so, well, that's a matter of coordinating. Sort it out.
Coordinate.
Yes. And when I do the walkthrough, I may upstairs this week, I may just mention that they may want to get something in there. Great.
Okay,
Thank you for flagging that.
Thank you.
so, thank you, that was good. But we're gonna replace you with
Yeah.
Representative Rebecca, who is here to talk with us about the 340B prescription drug pricing program, H266. Welcome.
Thank you. We all know
Never
Jen
had
is
my committee.
irreplaceable though.
Huh?
We all know Jen is irreplaceable though.
Very true.
What is really replaceable?
Jen.
Jen Carvey.
Oh, no.
But it's good to be with you all.
Think
Thanks
about
for
it.
having me.
Don't even think about it.
Have you had a walkthrough of the bill?
No, we're listening. Here's what we would like from you is kind of how the committee looked at the bill, just a brief introduction to the bill from your perspective. And then Jen is going to walk us through the bill in more detail. So I need to know you made changes, what you're thinking. was.
Got it. Okay. Perfect. And I can give you just sort of my write-up that I've done too, just of our intent with it.
That would be terrific.
Perfect. I'll send it to
Yes, if you send it to Kiki, we'll put it on and then it'll be extremely helpful to us because the quicker we can move through
you. Yeah.
your bills, the better off we are.
Wonderful.
Yeah.
Okay, so 266 is intended to protect the 340B drug pricing program. And it's critical that we do that so that our providers can serve Vermont's most vulnerable folks. It establishes important reporting requirements that will also bring increased transparency to the program.
What is a 340B? Are you going to talk about that a little bit?
I sure am.
That would be good.
Yeah.
So some members of the committee haven't even heard of it.
340B is a federal program that was established in 1992 to allow certain hospitals and health centers and clinics that serve vulnerable populations to purchase outpatient prescriptions at significantly reduced prices. And the goal is to stretch our federal resources, allowing the entities that are covered by this program to provide more of their comprehensive services to uninsured or underinsured folks. So think about our FQHCs or community health centers. So what they can do with the cost savings on these reduced price drugs is invested back into the community. So it allows them to not only do that, but offer reduced patient payments, increased access to dental care, and so on. So it's really a good program. Why do we need the bill now when we have so much other work to do in healthcare? Our committee felt we needed this now because the savings that are derived from participating in 340B are so critical to the operations and financial stability of our FQHCs and several hospitals in Vermont. But over the last 5 years, drug manufacturers have implemented several restrictions to the program. Remember, this is a federal program. They have changed the ability for healthcare organizations to contract with pharmacies in our communities, which has really reduced the savings that are available. That reduced funding has really put pressure on our already fragile budgets of these clinics and hospitals. So some of the critics of this program have noted that there's a real lack of transparency in it, especially around how the health organizations are using their savings. And we want to make sure that they're actually coming back to the communities for those programs that benefit our residents. So our bill, really strikes that important balance between providing insight into how those savings are used and the need to protect this program from further erosion of the cost savings. We think that the 340B, ensuring that those benefits reach our patients and communities. We think the bill is a structured approach to ensuring those things. We also think that it introduces accountability, transparency, and regulatory oversight to prevent the misuse of funds and protect rural and community pharmacies. I'm going to send you all a long list of all the folks we took testimony from, including medical centers, hospitals, and pharmacies, Association of Community Health Centers by state, laws, of course, VP of state policy at pharma, and so on. We also have a great page on our committee page with written testimony that was sent in, including from Eli Lilly and a international biotech firm, both in opposition. And I would just note that most of the opposition we received, in my opinion, was based on perspectives that are all outside of Vermont. So I would encourage you to look at the DFR 2022 report that Emily Brown testified on in our committee early in March. And that report really paints a good picture of the Vermont context, which I don't think is reflected in the letters of opposition, but you'll see that much of the national context and trends that happen with 340B are quite the opposite of what we see in Vermont. So what we want to do is really protect this program so that Vermonters have access to these pharmacies and the benefits of the program.
Thank you for that. That's very helpful. And keep you'll have the information that you send in, the witnesses and so on. That'd be good.
Great.
And we do have the report. We can get that. You can get that under this bill for us.
Perfect.
That's it. Questions?
Do you have questions?
For Representative Rebecca. Go ahead.
Not a question, more a comment, which is just to echo what my chair just said, that it's really I really appreciate it. I'm sure the committee does, that you've sort of teased out that Vermont, may not look the same as the rest of the country, and what is relevant elsewhere may not be relevant here. So I really appreciate that, because not just in this committee, but in other committees as well, that comes into play often. And so I really appreciate that.
It does, and I don't say it lightly because I am new to Vermont, and so I'm always really investigating when folks say, "Well, Vermont's different," because I want to make sure we're not living in a bubble, right? We need to innovate. I mean, we're in many health crises right now, and so always push us to innovate. So when someone says, "Well, Vermont's different," I really question it. In this case, I think we have data to really back that fact up, that in this case, Vermont is different. So again, look to that DFR report, and again, a long list of witnesses that we saw in House Healthcare that really proves that fact.
Other questions? Thank you. Thank you very much. And we look forward to seeing whatever you send us. We'll have it on our webpage
Wonderful.
for the bill.
And thank you so much for picking this up.
Yeah, no. I think we will. I do think we will pick it up and understand. So Jen, given that,
I have to head up and down that house.
okay, good luck with that. Fun.
Is it house or something?
House on the mezzanine now,
It's on the mezzanine.
over by the coat room, the stairs over by the coat room, there's one floor. Yep.
Okay, thank you.
Break a leg.
No, don't do that. Please don't do that.
Thanks a lot.
That's
Senator.
theater talk. It's theater talk.
I've already broken
Maybe
enough
it's good
legs. I don't want to break a leg or a heart.
All right. Again, Jen Carvey from the Office of Legislative Counsel and put up page 266. And this is an act relating to the 340B prescription drug pricing program. So you heard a good overview from Representative Rebecca. This bill would add a new subchapter in Title 18, Chapter 91, which is on prescription drug cost containment. This would add a new subchapter 6 on the 340B drug pricing program. It starts out with several definitions. So as used in the subchapter, a 340B contract pharmacy is a pharmacy that has a contract with a 340B covered entity to receive and dispense 340B drugs to the 340B covered entity's patients on the covered entity's behalf. So it's a pharmacy that the covered entity, the one that's eligible to participate as a in the 340B program as a covered entity contracts with to receive and dispense 340B drugs to patients of that covered entity. 340B covered entity is an entity participating or authorized to participate in the 340B drug pricing program as described in 42 USC 256B, which is where that lives in the federal statutes. The term includes a 340B covered entity's own pharmacy. 340B drug is a drug that has been subject to any offer for reduced prices by a manufacturer pursuant to that federal law and is purchased by a 340B covered entity. A discount is a reduction in the amount of a 340B covered entity that a 340B covered entity is charged for a 340B drug at the time of purchase. Yeah.
I want to go to number 3. So that means that the manufacturer is making a determination that this drug can be entered into the 340B program. What does that mean?
This is a drug that it's my understanding, and others who know more about the 340B program can explain it better. But the manufacturers are required by federal law to participate in the 340B program if they are offering their drugs in the Medicaid program, I think. One of my go-tos. Thank you.
That's important verification. Thanks.
Yes. Manufacturer has the same meaning as in our pharmacy statutes. That's what that cross-reference goes to. Pharmacy means, this is a definition from the pharmacy statutes as well, a place licensed by the Vermont Board of Pharmacy at which drugs, chemicals, medicines, prescriptions, and poisons are compounded, dispensed, or sold at retail. Pharmacy benefit manager has the same meaning as in the chapter that was added last year or 2 years ago on pharmacy benefit managers in Title 18. And finally, a rebate is a discount in which the terms are fixed and are disclosed in writing to a 340B covered entity at the time of the initial purchase of the 340B drug to which the discount applies, but which discount is not applied at the time of purchase. That's sort of what you would think of as a rebate, where you don't get it at the point of sale, that you get it later to reach out for it. All right, so then we have discrimination against 340B entities prohibited. This prohibits a manufacturer or its agent from denying, restricting, prohibiting, or otherwise interfering with, directly or indirectly, the acquisition of a 340B drug by or delivery of a 340B drug to a 340B contract pharmacy on behalf of a 340B covered entity, unless receipt by the 340B contract pharmacy is prohibited by the U.S. Department of Health and Human Services. So this is looking at some existing or recent situations in some places where the manufacturer has said, we're not doing 340B drug pricing if you're using a contract pharmacy. And this is saying you have to under Vermont law unless the federal government says that's not okay.
Okay. So leave it in statute.
I'm sorry, did Representative Rebecca say how many of these entities there are in the state? Do we have a sense of how many?
Of the 340B covered entities?
Yeah.
No, I don't think she did, but some of our other witnesses may be able to tell you. I mean, it's I believe all of our hospitals and federally qualified health centers and Planned Parenthood. Those are the main ones that I'm aware of that qualify under the federal law. And then the contract pharmacies are additional pharmacies that they contract with to help them implement the 340B.
Got it. Thank you.
All right, so that says to the manufacturers, they have to let 340B covered entities use a contract pharmacy unless federal law says otherwise. or the federal government says otherwise. A manufacturer or its agent in subsection B shall not directly or indirectly require a 340B covered entities to submit any claims, utilization, encounter, purchase, or other data as a condition for allowing the acquisition of a 340B drug by or delivery of a 340B drug to a 340B contract pharmacy unless the claims or utilization data sharing is required by the U.S. Department of Health and Human Services. So here it's saying to the manufacturers they can't require additional information to be submitted or otherwise provided by a 340B covered entity in order to allow the use of a 340B contract pharmacy unless that is required by the federal government. And I will just note there has been litigation on this topic of contract pharmacies. I believe so far the federal government and the courts have allowed the use of the 340B contract pharmacies, but it's not something that the manufacturers are in favor of. This subsection C, a manufacturer or its agent shall not interfere with the ability of a pharmacy contracted with a 340B covered entity to dispense 340B drugs to eligible patients of the 340B covered entity. So manufacturer can't get in the way of a patient getting their drugs from a 340B covered entity, a 340B contract pharmacy through a 340B covered entity. And finally, a manufacturer or its agent shall offer or otherwise make available 340B drug pricing to a 340B covered entity or 340B contract pharmacy in the form of a discount at the time of purchase and shall not offer or otherwise make available the 340B drug pricing in the form of a rebate. So the purpose of the rebate definition is to say, don't do a rebate. It has to be at the point of sale. Section 4683 would just say nothing in here should be deemed to apply to Vermont Medicaid as a payer. Or entirely carving out Vermont Medicaid, which was more of an issue in the bill as introduced that had provisions that affected health insurance, but in this case, still carving it, being specific that Medicaid is not implicated.
Okay.
4684 violations, a 340B covered entity, contract pharmacy, or other person injured by a manufacturer's or its agent's violation of this subchapter may bring an action in Superior Court for injunctive relief, compensatory and punitive damages, costs and reasonable attorney's fees, and other appropriate relief. This is a private right of action. So this doesn't require the state to enforce. It allows a covered entity, contract pharmacy, or someone else who is injured by a violation of the subchapter to bring legal action. And it specifies that a violation occurs each time a prohibited act is committed. So for purposes of section 4682, that's all the prohibitions on the manufacturers. A prohibited act is defined as each package of 340B drugs that is subject to a discriminatory action by a manufacturer or its agent. Section 4685 finally says, nothing in this subchapter should be construed or applied to conflict with or be less restrictive than federal law for a person regulated by this subchapter. So we're deferring to federal law, saying we're not trying to conflict, but also we may be being more protective. Section 2 is on reporting on participation in the 340B drug pricing program. This language was originally proposed in a different bill, and these bills were kind of combined in the House Healthcare Committee. This would require that annually on or before January 31st, each hospital that participates in the 340B drug pricing program would have to submit to the Green Mountain Care Board a report detailing the hospital's participation in the program during the previous hospital fiscal year. And that report would get posted on the Green Mountain Care Board's website and would contain at least the following information. First, the annual estimated savings to the hospital from participating in the 340B program, comparing the acquisition price of drugs under the 340B program to group purchasing organization pricing, so non-340B. If group purchasing organization pricing is not available for a specific drug, then the hospital must compare the 340B acquisition price to the price from another generally accepted pricing source. They must report the aggregated amount that the hospital, payment amount that the hospital made to pharmacies with which it contracted to dispense drugs to its patients under the 340B program during the previous hospital fiscal year. So aggregated amount they paid to contract pharmacies. the aggregated payment amount that the hospital made to any other outside vendor for managing, administering, or facilitating any aspect of its 340B program during the previous hospital fiscal year. The number of claims for all prescription drugs the hospital obtained through the 340B program during the previous fiscal year. A description of the ways in which the hospital uses savings from participating in 340B to benefit its community through programs and services funded in whole or in part by savings from the 340B program, including services that support community access to care that the hospital could not continue without the savings. And finally, a description of the hospital's internal review and oversight of its participation in the 340B program in compliance with the federal program rules and guidances that US.
So that would be, they're also, making a report to HHS.
It's just a description of how what they do to comply with the US Department of Health and Human Services, Health Resources and Services Administration.
Okay.
First,
You can.
yeah, so a description of what they do, of their own internal review and oversight of their participation in the program in compliance with what's required already by the feds. Section 3 is a sunset, so that reporting requirement, the 340B hospital reporting requirement, would be repealed on January 1st, 2031. So it's just putting a 5-year sunset on. And then in section 4, the act would take effect on passage with the first report under section 2, the hospital participation in 340B, due on or before January 31st of 2026. So you get it 26, 27, 28, 29, and 30, and then it would go away before unless you take off the sunset.
So I'm thinking that section 2 was put in because there were concerns about the use of funds.
I think there is interest, and I'm sure other witnesses will tell you
Yeah.
in more detail, but interest in what how the hospitals are using their 340B, what their savings look like and what they're doing with those savings
Got it.
based on the purposes for the 340B program under federal law.
And this came from another bill, so there's 2 bills together. That's nice.
Right, this came from another, as part of a larger bill, that was supported by the Office of the Healthcare Advocate. And so this piece was pulled out of that bill and put in as related and of interest to members of the committee.
I forgot to ask Representative Rebecca what the vote was in the committee
I
on
think
this.
it was 11-0-0, but I
Okay.
will, yay, I will try to take a look. Yeah, many things have come out of that, or maybe 10-0-1 if we were missing something that day, but
That's good. Well, we sorted out.
it's usually on their website.
She might have about her report too. She's submitted.
Oh, yeah, good thought. Okay, so this is good. All right, so,
And then can I
What?
take us back to our last bill for one
yes.
moment,
yes,
just
you
because
may.
I looked at the language,
Page 90.
10-0-1 was the vote on 266 before we leave that 10-0-1.
10-0-1.
Yes,
Yeah, she said that with one absent.
okay,
She did say that?
Yes.
I missed it. Thanks.
all right, and then I just wanted to put up,
Maybe it was very close.
What did she say?
We don't know which bill it
That
was.
was the first bill.
It was a 10-0-1.
Oh, okay, yeah, it was
One of them has
10-0-1.
somebody, yeah.
Just a little.
Yeah, you're right.
all right, so we have been talking briefly in the other bill about the birth centers and whether there should be a carve out in the
Yes,
and
yes.
the transfer of ownership. And so I just wanted to revisit for a moment before I go further. So this is S18, this is from the Senate calendar. And I don't know that anything is required to change because section 3, where the exclusion is, excludes from the entire subchapter on certificate of need. So excluded for the entire certificate of need subchapter are offices of physicians, et cetera, and the exclusion, and then we added for the bill, the exclusion provisions would also apply to birth centers. So I don't think it makes sense to specify in 9434 that birth centers are excluded when they've already been excluded from the entire chapter. I think it calls into question
We
whether.
don't need the
whether we
Department of
need to-
Redundancy.
Right, I think it,
Got it.
if they're not subject to the subchapter, if they're not subject to the subchapter.
Okay.
We can certainly confirm with the Greenmont Care Board that that's how they would
It still,
understand
it
it.
still seems like an odd provision unless I'm not understanding it, but if you weren't subject to a certificate of need from the onset, why suddenly when you change hands, do you need a certificate?
You're on subject, you're not subject to it. You're out of
If you're not, I think if you're not excluded from the subchapter, it could be an open question. If you qualify as a healthcare facility, but you didn't do things that triggered a certificate of need, but now you're changing ownership. I mean, you may have existing facilities that were in place before the certificate of need statutes were even adopted that didn't, or that, didn't meet the threshold when they were created, but in changing ownership would need a certificate of need for that. It creates some review. They're talking, as you may have heard upstairs, about private equity and acquisition of healthcare facilities and change of ownership. And so there may be some rationale there. But if we're excluding birth centers from the subchapter, I would be reluctant to specifically exclude them from a piece of the subchapter as though they weren't exempt from.
That's helpful. And this probably isn't the end of this conversation, I would think, but as we go through H96.
Right. And certainly welcome.
And whatever's happening in the
thoughts from the
house
board or
with S18. So there'll be kind of that
yes.
iterative process and alignment
Alignment and alacrity.
with alacrity. Okay.
Thank you.
So Jen, thank you for this. And we're so committee, we're good. Great, thank you. So committee, we are going to be looking at bills tomorrow. Again, we'll be looking at House bills. We're going to adjourn early today. And so Senator Bulick, you said that Josh Miller from the family room might be stopping in because he had asked to stop in. Was he gonna stop in? Okay, all right. All right. So if okay, so we're going to adjourn for the day and we'll be back tomorrow morning at 9 o'clock. We have a little bit of time. I personally need it and I think maybe all of us could use it. And then tomorrow we'll dive in again. And I just want to say that the House has done significant work on the bills that we're looking at. So we'll see all of the testimony that they've taken. And our goal is to look to see how we might improve the bills. We'll listen to folks who have concerns on the bill or support for the bill and try to move as it's going to say that word. We'll move as quickly as we can to try to get through some of the work because the House has done a lot of work already. But we have a lot to do. And we do have a short time. And we do have a large bill coming to us called H91 on the GA housing issue, general assistance work. So that bill may require more in-depth work.